like to start on time at 6:30. Once again, I want to, on behalf of my co-founders and directors of CVI, Dr. Manos Bellakis, Subhash Banerjee, and Paul Saraja, and I'm Mehdi Shishabur. We want to welcome you again to CVI. This is our ninth year, and we couldn't have done it without you and your support. And this is the ninth year that we conduct the Innovation Summit, which is usually on a Thursday night. And we've been very fortunate because we have been able to invite very elite, innovative, thoughtful, visionary speakers to join us. And tonight we have a very special treat for you. I'm going to invite my partner, Dr. Manos Bellakis, to invite and introduce our guest. And then at the end of the presentation, we do a little bit of a Q&A and hopefully get your questions answered and have a good interactive session. Thank you so much, Manos.
Wonderful. Thank you so much, Mehdi. And again, it's my great pleasure to introduce Dr. Charles Taylor. He's the Moncrief Chair in Computational Medicine, Professor of the Department of Telemedicine, which is fairly unique for an engineer by training. And then he's, as you know, there's a new medical school here in Austin, University of Texas Systems, which is phenomenal, as you'll hear from him as well. He trained in the Rensselaer Polytechnic Institute and did his PhD at Stanford University, where he was from 1997 to 2010. Then what you're probably going to hear about, Charlie Taylor, he is the co-founder of HeartFlow. So a lot of the things you hear today in the city-guided course, in the city training yesterday, comes directly from his efforts that started way earlier, before many of the rest of us got involved into this. Apart from that, as you will hear, he's also an amazing human being. He helped us very early on to learn in a very considerate way, trying to help us from the small steps, the basic things we didn't know that we had to learn. I'm thrilled to, again, introduce Dr. Charlie Taylor. He's been a mentor and a great supporter, and we're very excited to hear from you. He was doing AI and ChatGPT like decades before the rest of us joined in. So, Charlie, thanks so much again. We're thrilled you can join us tonight.
Well, is this mic working? Yeah, thank you. It's a pleasure to be here. It's been a couple of years since I've been here, and it's wonderful to see how the meeting has grown. The participation of industry as well. So really, again, a pleasure to be here, and it's really actually humbling to see some of the products that we had created over the years to be in clinical use and to be discussed. I'll get started. Let's see, this clicker is not. Is it me? Clicker's not working. Oh, yeah, there we go. Okay, good. So an obvious disclosure, so I co-founded HeartFlow. I'm still on the board, shareholder of HeartFlow. Do I got to point this somewhere? Point it that way, okay.
He's coming to help you out. There's something with the clicker, so sorry for that.
Okay, that's all right. Is there a better clicker? Ooh, look at that. Somehow, somebody, I don't know how it advanced without it being on before, but maybe just willpower. So the work that I did actually started from about 30 years, a little over 30 years ago when I was a graduate student at Stanford. And I remember I was starting to build computer models of blood flow in the circulation. And I remember being in the lab one day, and we had a radiology faculty that actually was doing the very first CT angiography, not in the heart, not in the coronary arteries, but in the peripheral vascular circulation. And I was in vascular surgery as well as in engineering, and was starting to put these technologies together. I remember seeing a CT angiogram of a patient with abdominal aortic aneurysm, and it was really remarkable to see that for the first time 30 years ago. And then the idea was, how do we actually extract information and to understand how blood flows through the circulation by building patient-specific models. So this is how my career started. Still not, oh, there we go. I was in vascular surgery, and we started to think about, now not quite 30 years ago, but 27 years ago, started to think about how do we actually build software tools for planning surgical procedures. I think some of you saw the HeartFlow's planner technology. The idea behind this was, quite a long time ago, but the idea is, could we actually build computational models, plan vascular surgical procedures on the computer, evaluate alternate treatment strategies, and then to be able to use this information to go forward, improve patient care. In 1998, we built a software system running out of a web browser. Again, this is a long time ago. None of you probably have ever seen that web browser before, many of you in Netscape. And old computers, by today's standards, but actually starting to talk about the idea of surgical planning for vascular procedures. And I wrote this paper, now published about 25 years ago, this idea, how do we think about medicine from not a diagnostic empirical paradigm, but how do we think about using tools like this to try to predict outcomes for interventions, for individual patients' anatomy, physiology, to help enable physicians to, quote, design improved patient-specific treatment plans. So we started at Stanford building the tools to do blood flow modeling from image data from head to toe. This was literally a simulation like this from head to toe. Back in those days, it required some of the biggest computers available, but now it's, these things can be done on your phone, your iPhone or an iPad these days. And the research that I did at Stanford, these are the 25 doctoral students and postdocs that came out of my lab, and really that was a period of about 14 years. We're really starting to build some of the core technology, understand how to move this forward, and is supported by National Science Foundation, National Institutes of Health. So I was on sabbatical from Stanford, was thinking about what to do next, learned a lot about physiology, about coronary physiology, about fractional flow reserve. One of my colleagues at Stanford, Bill Fearon, was a young fellow at that time, and he was starting to use this, these techniques for invasive physiology being developed mostly in Europe with Bernard de Bruyne and Nico Pals. And I had the idea that maybe we could do this non-invasively from a CT scan. And I'll talk a little bit more about this. But this is the genesis of the idea. Around 2008, I started the company in 2010. And actually left Stanford in 2011 once it had started to take off. So the fundamental question, obviously, for a patient who has suspected coronary disease, symptomatic patient, is trying to understand, do they have, many of these patients, maybe about a third that you typically do CT on, do a CT scan, you'll find no coronary disease, clean coronaries. About a third could be managed with medical therapy. Roughly a third might need further invasive assessment or an intervention. And the question is, how do you understand what pathway to take based upon the presentation of the patient? I have to say what's inspired me to think about this, again, the role of non-invasive imaging, after reading this paper, Eugene Braunwald, and the idea, again, is to start to, he was talking about Framingham risk scores, to start to understand how to risk stratify a patient, and on the basis of those risk scores, to decide who is the right person to get non-invasive imaging. And then the goal of non-invasive imaging is it doesn't always have to be the final diagnosis, but how do you risk stratify patients into those that could be, reasonably managed medically versus those that need further invasive evaluation. He wrote this in the context of looking at vulnerable plaque. I would say this absolutely holds for CT-derived plaque quantification, for physiology, et cetera. But this is the lens that I've looked at these problems through. Again, it's not non-invasive or invasive assessment, non-invasive plaque versus invasive assessment. It's how do you use these technologies in a staged manner to be able to get the right patients in the cath lab that will be most likely to have atherosclerosis, most likely to benefit from intracoronary physiology assessment, et cetera. The challenge was, really at this time, and there's a lot of discussion about this, right? Non-invasive functional tests were limited in detecting obstructive coronary disease. And, everybody probably knows of Manish Patel's paper early on in New England Journal. He showed that, more than 50% of patients sent for an angiogram do not have obstructive coronary disease, defined by a greater than 50% stenosis. And this was just a failure in part of the non-invasive testing strategies that we had at the time. It's a little more complicated than that, but that's a lens that we could look at it. We could say those patients are false positive. The other concern is that with existing non-invasive functional tests, that you might miss coronary disease. You might miss significant coronary disease in these patients. Part of that is just the simple fact that we can get a lot of atherosclerosis, development of atherosclerosis, before it ever narrows the lumen. This idea of compensatory or Glagoff remodeling. I had the pleasure of spending some time with Seymour Glagoff. My colleague, Chris Ahrens, worked very closely with him at University of Chicago. But the idea is that as you have development of atherosclerosis, it can get quite an atherosclerotic burden before it becomes anatomically significant. And then it has to become even more, you have to have more disease before it ever, narrows the lumen, before it would trigger a perfusion deficit, a wall motion abnormality, EKG changes. So this idea of the ischemic cascade. So you cannot see a lot of coronary disease with an existing functional test. It's just invisible to that. That's the power of doing an anatomic imaging as well. So one of the reasons is you can have diffuse coronary disease also. So you take a patient in the cath lab, you don't see focal stenosis. Well, that's not the only thing that causes flow limitations, functional limitation. With diffuse coronary disease, you can have low FFR. That was shown by Bernard de Bruyn. I like this study with Toth. About 30% of lesions with less than 50% were still FFR positive. That's because diffuse atherosclerosis can cause physiologic flow limitations. I did a study to look at, it's not just diffuse atherosclerosis, by the way. Some patients have small caliber epicardial vessels indexed to their mass, the quote, low volume to mass, and there's a normal distribution of that. In patients like that, they could have no coronary disease, but their vessels are small, and you see a functional limitation if you were to actually measure FFR. It's surprising that that's the case. That's physiology. That's the reality. So we of course talk about, from non-invasive limitations of non-invasive imaging. Okay, let's go to the cath lab. Let's think about that. And of course, it's a 50% diameter stenosis. I don't know if anybody of you met Lance Gould, by the way, before. He's a legend in coronary physiology. I would say he did this work 50 years ago. So I've been at this for a long time, but 50 years ago, did this experiment in dogs, putting a restrictor around the LAD in a dog model, and showed that once you got to about 50% obstruction, the stress blood flow started to fall off in the cath lab. That's why we have a 50% diameter criteria. That's it. Those experiments in dogs done 50 years ago. A decade afterwards, 40 years ago, there was a study published in New England Journal of Medicine that more or less says you shouldn't do this, right? These results should be profoundly disturbing, but today we still have this idea we got to look for a 50% stenosis. We call it non-obstructive. It's less than 50, obstructive greater than 50. It's just more complicated than that. And I'll tell you, if you talk to Lance Gould, he won't talk about diameter stenosis. Of course, he's one of the fathers of cardiac PET imaging as well. So, and also was very involved in the development of fractional flow reserve, invasive physiology assessment. Coronary flow reserve, for a lot of reasons, can be difficult to measure in the cath lab. Fractional flow reserve pressures don't vary over the cross-section of the vessel. It's really easy to get a reliable pressure measurement at a location along the length of the vessel, compared to doing coronary flow reserve measurements. It's just physics. This technique has really taken off. And, as I said, for me, I started thinking about this when before I met Nico and Bernard, but they asked me to call FFR CT. I was calling it CT FFR. They asked me to call it FFR subscript CT because they viewed this as just another way of doing FFR, albeit derived from a CT scanner. So this was the observation I had, and I've got to credit Manish Patel for this kind of framework of this slide. So obviously, we can do things in the cath lab. It's remarkable what is possible in the cath lab, but we got to bring the patient to the cath lab to be able to do that. But with Manish's data, only about 40% of patients actually enter the cath lab have obstructive coronary disease. 60% don't. So if we say, well, we're not going to do FFR, maybe in a vessel that doesn't have obstructive lesion, we won't even do physiology assessment. Well, only 40% of patients have obstructive coronary disease. If you look at the FFR literature, only about 40% of those lesions that are interrogated are positive by FFR. So 0.4 times 0.4, 16% of lesions that you would expect based upon traditional non-invasive functional testing would go to the cath lab and have what I would say would be a pretty clear target for revascularization, right? A focal area of narrowing, focal obstructive disease, and have a flow limitation, a functionally significant flow limitation. So the question is, could we do a reasonable job of identifying obstructive disease before the patient went to the cath lab? Obviously, it's not going to be perfect, but if we could develop a test that especially had a high negative predictive value, right? We don't want to, if the worst thing that happens with a false result is a patient gets an extra trip to the cath lab, well, you're still significantly decreasing the number of patients going to the cath lab. It was really an emphasis on trying to minimize false negatives, even though, again, that might come at the expense of having some more false positive cases. So that was the idea. Well, it was clear to me, back in that time that CT was remarkable even at that time. We had the first dual source CT scanner. I think the first patient we imaged was in around 2007, 2008, first Siemens generation scanner. And it's changed remarkably, from that time. What CT can do today versus then is remarkably different. But what it's really good at is getting very good anatomic images. The challenge was the physiology. How do we get a non-invasive fractional flow reserve? Now there's a lot of efforts, to quantify FFR from CT data, HeartFlow, Siemens, Canon, there's a bunch of companies that are doing this now. There are 2 FDA cleared products. There's HeartFlow, and then there's a Kia Medical, a Chinese company that also has an FDA cleared product. So I'll tell you about the HeartFlow approach, and really it's conceptually. The way I always describe it, there's anatomy, there's physiology, and there's physics. Like the complex flow characteristics, that's the physics. That's actually the easy part now. But it's the hardest part of the problem is understanding how to extract good anatomic data from a CT scan. And by the way, with discordant results, this is almost always the source of explanation for a discordant result between an invasive FFR measurement and a prediction. It's the ability to be able to extract a high quality anatomic model. And I'll tell you more what that depends upon. So, and this is going to be where the AI comes in. So, when we first started doing this, everybody talked about CT, and they said, well, you can't do a CT scan with a patient over a calcium score of 400. Do a calcium score first. You just can't do it. It's non-diagnostic. It's not worth your time. So when CT started, people said, this is a modality we're going to use as a rule-out test. So everybody that went to a CT scanner were low-risk patients. It was a low-risk rule-out test. So patients with a lot of coronary disease, nobody would send them to the CT scan, right? So patients going on to the cath lab with a lot of coronary disease or going to surgery, CT just wasn't being done in these patients. So in order to make that happen, you have to be able to deal with processing and analyzing these really tough patients and getting accurate anatomic data from really difficult patients. This is a case from a study we did called Fast Track CABG. Patients went from a CT scan to bypass surgery. This was a study Patrick Sorois was PI on, published in European Heart Journal. So this is routine. HeartFlow doesn't have a calcium score cutoff. I would say the highest score was 10,000 from the great state of Texas, where everything is bigger, including calcium scores. But that was the highest reported result. And it is hard, it's difficult to be able to interpret data, but I'll tell you how it works. So this is by far the hardest part of the problem. How do you extract information from medical images, especially if you have motion, if you have poor opacification, you have a lot of disease like calcium. So AI to the rescue. I hope, since I moved to Austin in January, my kids tease me because every time I see a Waymo without a driver, I'm like, look, there's a Waymo without a driver. But the problem is in Austin, you see it everywhere, right? I mean, if you go around the city, it's everywhere. Well, this came from California, from Google. Those folks pretty well who actually started Google, but also the people doing Waymo, creating Waymo. It's pretty remarkable, right? Is that it's a computer vision problem, and I'm going to tell you a little bit about that. But now now there's a lot of AI in healthcare. This story is more than 1,000 AI models, many in cardiology. Now it's about 1,400, almost 1,500 FDA cleared AI products. Okay, all over. So there's been a lot of opinions of different people. He's pretty well known. He won the Nobel Prize, right? But he talks about he made a statement back in 2016 that actually caused a lot of controversy in the radiology field because he said we should stop training radiologists. They're going to be extinct, and you can read the quote. You know, if any of you watch those Bugs Bunny cartoons or the Roadrunner, you know, the idea that we just should stop doing that because it's going to be taken over machines. Bill Gates, you know, both doctors and teachers are going to be, you know, out of business within 10 years. Humans won't be needed for most things. That's great. Yep, it's very encouraging. Well, they're completely wrong, to tell you the truth. They've never built a product in healthcare, with all due respect to both of them. So what do real experts think about this, about the role of AI in healthcare? So I decided I would ask ChatGPT. So will AI replace doctors in 10 years? I mean, you got to go to the source, right? So no, AI will not replace doctors in 10 years, but if you read it, and you can do it yourself, and it's actually pretty well thought out, right? I mean, way better than what you'd hear from Bill Gates or Jeffrey Hinton. But there are things that are powerful. And the truth of the matter is, I think most people would agree that this is going to be a tool that you can leverage. You know, I think that will be better doctors. I'm a little scared, you know, about it for a lot of reasons. Like my kids, like, will they learn how to write an essay? It's pretty easy to put this into ChatGPT. I mean, it's going to change so many things in such a fundamental way, but I think it's going to be helpful and powerful, but no, nothing to worry about. I don't see this replacing doctors. And I did ask ChatGPT to create a picture of Mark Twain with his quote, and as a doctor, did a pretty good job of that, just very simple prompt. So reports of my death are greatly exaggerated. This is nothing to worry about. But how can we leverage artificial and human intelligence to extract human anatomy? By the way, that's what Waymo does. They leverage artificial and human intelligence. So how do you do that? So this is the secret, you know, to HeartFlow success. I'll tell you, any company that's going to work in this area, they're going to have to do something similar. First of all, if you want to figure out how to read a CT scan, non-invasive data, look at the ground truth. Right? Look at the ground truth. You're going to see the ground truth much better in a cath lab. To have those patients that have a CT that go to a cardiac cath lab and fuse the data, put the data with IVUS, with OCT, with angio together, and use that to learn how to better read a CT. By the way, that's how most people get better at reading a cardiac CT, is by having angio correlate, cath correlate. So that's the first thing. And you fuse the data together. You can say, this is what IVUS says. You know, this is what I get from the CT analysis, and you change the parameters of your model to best match what you can see in IVUS for those patients. And then you use that going forward for the next patients that maybe are not going to go to cath. So we did this, and I'm a huge believer, and we got to break these barriers down between the non-invasive and the invasive world. The non-invasive technology will get much better with invasive data. That's true for physiology, for atherosclerosis, for vulnerable plaque, all of these things. But it also is helpful when you look at from an invasive perspective. The non-invasive gives you the global picture, the big picture. You're not going to interrogate every vessel with OCT, with IVUS or FFR, but to get a global picture and then to get the more detailed information in the cath lab, I think is the way to go. So we fuse the data together. You can't figure out where, you know, the boundary is from the CT scan. You know where it is from OCT. If you overlay the data, you can validate your techniques, but then you can make them better. So that's the first part of the story. The second is the human in the loop. And this was a decision that I made early on out of necessity. Everybody, all the imaging companies were saying, no, you got to build a software system, put it in a hospital, doctors, techs are going to use it. And I said, with all due respect, we need to pull the data out. And we need to process it in essentially a core lab type of environment, and in a very consistent manner. So we built the software system to just look at the data and to actually inspect and correct. So it's a beautiful visualization system for actually extracting information about the coronary arteries, but it's never used, you know, in a hospital setting. It's used in the central processing facilities at HeartFlow. There's one here in Austin. There's about 150 people that work there that are sitting in front of a computer, getting image data, getting automated algorithm results, and inspecting and correcting. So there's roughly 200 people, you know, the company that do this. They do about 2,000 cases, 2,000 patients a day, you know, roughly. And it's automated algorithms, deep learning algorithms with human correction inspection. And what happens, why that's special, is that those things that you learn about an individual case and the corrections you make are then learned and fed back into future generations of the algorithm. So that's what Waymo did, right? They had people driving these vehicles around, teaching a computer how to drive, and then they had the people do fewer and fewer tasks, and then ultimately you got to the point you say, okay, it's pretty darn safe, we can take people out. There's still certain circumstances we have somebody who kind of calls in, so to speak, to control the vehicle. But in HeartFlow, I don't expect we'll take the people out of the loop. It'll continue to have that, people that will be doing the inspection correction. So that's an important part. The third part of it is also really important, is that, the reason why aviation is so safe is that over all of those years, in the early days of aviation, when there were problems and things didn't work, people figured out why. You do root cause investigation. That's like engineering 101. Root cause investigation, find out what went wrong so it doesn't happen the next time. And with HeartFlow, because the data was, the analysis was done, the results were sent back to an institution, and probably every interventional cardiologist on the planet, when they first used it, kicked its tires, tested it out to see if it worked in their own hands. Anytime I would go visit a customer, I would say, complain about our product. Really, if it's not working, provide that feedback. So that feedback, you can then figure out what went wrong and how to make it better. So in the early days, I have to say I was pretty nervous, the very first FFRCT analyses that were sent out. We knew from the clinical trials and the validation studies how it was performing. But what we were able to do, and there's no product on the planet that has a false positive, false negative rate of 0.5%, right? Nothing is that good. I just show this because it's the trends. Over time, with feedback, with a very active effort to be able to do root cause investigation to find out reasons of discordance, you can provide an improved quality of product. So those are the things. It's this type of feedback. And if you don't have a system where you have a mechanism for getting feedback from physicians that are using your product, you can't improve it the same way. And I would say there's a lot of products that you all use, and trust me, you don't have an easy way of providing feedback into the manufacturers of that product that will, in a real time, will make it better. Okay, so that's the hard part. The easy part is the physiology. I wrote a paper in JACC now 12 years ago. It's there's a couple of updates to it, but it's really from a static CT. How do you derive physiology information? It's using information about the anatomy, about myocardium, using the fact that how vessels branch gives you insight into how blood flows to different regions of the myocardium, and then a model for vasodilation for physiology. You can look at that paper. And then the last part is the physics. That's where a lot of math comes in. It's now, these calculations take about a second or so after all the other work is done. So it's fast, and this is why it can be done on an iPad or an iPhone. And then you provide the data, all vessels over 1.8 millimeters in diameter, because below that it wasn't validated with invasive FFR measurements. So for regulatory reasons, you can just provide it vessels over 1.8 millimeters. So there's been a lot of studies, a lot of publications. Accuracy was obviously the first thing that we had to look at, but a lot of other clinical data. Just show one of the accuracy studies. This is the fourth out of fifth, published in JACC in 2019, and it was comparing to CT alone, PET and SPECT, diagnostic performance. Again, you're never going to get something perfect against invasive FR. That's the reference standard. So the question is, for available non-invasive tests, how well does it perform? And especially, how do you make sure you have a high negative predictive value? So if even if that means that your positive predictive value is a little lower. This is one of the studies I have to say most proud of. My co-founder, Chris Aarons, is a vascular surgeon. He kept saying, all these patients that go to that have peripheral artery disease, and they have chronic limb-threatening ischemia, or they have carotid disease. That's not what they die of. They die of coronary artery disease, and most of the time that disease never gets detected. So he really has been driving this idea, let's take this patient population who's not getting CT, who's not getting evaluation. They're technically, not always the ones presenting with chest pain. Well, if you have chronic limb-threatening ischemia, you may not present with exertional chest pain. But what he showed is that by using this information, this is just doing the CT to detect disease, understanding physiology, but actually most importantly is finding disease, really significant lesions that when treated, when intervened upon, often with revascularization, PCI or surgery, you improve outcomes. That's good to know that, right? That revascularization in this patient population can lead to improved outcomes. This is survival, right? Hard endpoint. The guidelines in the UK, the UK was the first to really go lean hard into CT, changed the chest pain guidelines in 2016. In 2017, HeartFlow had a positive review from NICE, National Institute of Care Excellence. And then it was in 2021 was the first product to be mandated in all of the UK in NHS England hospitals. I show this. This is the front page of London Times. 2 matters of the heart. Bill Gates' divorce, and then there's a discussion about HeartFlow's scan there. Anyways, as a result of that, actually now the UK is very forward-looking in this regard. There actually are 4 AI products that are mandated by NHS. Two of them, relate to heart disease. Kerry Hart is from the Oxford group on fat attenuation index, and HeartFlow is the first one. So they were able to do a study before introduction of the technology till after 90,000 patients evaluated national level, and what they showed is that they actually saw a reduction in invasive diagnostic catheterization, that patients were being diagnosed, more often with a non-invasive strategy than, after it was introduced than before. The chest pain guidelines were updated in 2021. Actually, this happened after, in 2020, there was a meeting by ACC convened at a Heart House to really look at, how do we think about this new technology, and should cardiology really lean in, to CT as a frontline test. The big decision that was made was CT became level 1A evidence, the only level 1A test. Stress testing is level 1B, and they also included FFRCT in the guidelines for after you identify disease based upon CT. I will tell you that the morning that the guidelines came out, the American Society of Nuclear Cardiology had an editorial in Journal of Nuclear Cardiology that said they would not endorse the chest pain guidelines. Their number one reason was that FFRCT was featured too prominently. I suppose it was because it says it's above stress testing in the, I don't know. But anyways, this is, obviously there's pushback when you introduce these new strategies. But I have to say I'm a firm believer in patients who are trying to look at anatomy first, identify, does the patient have clean coronaries, do they have obstructive disease or not, and then trying to understand functional significance of disease. FDA considers this as software as a medical device, and in a paper in New England Journal of Medicine AI, there's a whole bunch of technologies, now 1,400 technologies cleared by the FDA, but less than 10 of them are actually getting adopted as evaluated by Medicare claims data. So they're there, they're available, but anybody doing this, you have to take that next step and bring the product forward and to be able to think about payment and reimbursement systems. If it's not getting paid for, then it's hard to use this. And now this technology is by Medicare, many Medicaid, not all Medicaid plans, and essentially all private insurers. Now you can go beyond just the physiology. You can get information about anatomy to help read the CT, very simple matter, and then also atherosclerosis. And now there's 3 FDA cleared products that are considered in this category of AI quantitative coronary plaque analysis. Clearly was the first one, as Jim Min's company. Elucid, the second one, they're actually the oldest of all of these companies, been around the longest. And then also HeartFlow has an FDA cleared product. Again, going back to the question of does it work compared to what's going on in the cath lab, evaluation was done. This is Jagat Narula was the PI, first author. Again, Akiko Mahara ran the core lab for IVIS, and looking at what you can do. And the truth is, what you can do from CT, you can do a good job with calcium, you can do a good job with estimating non-calcified plaque. It's pretty hard to get lipid-rich plaques, LRP. It's pretty hard to do that from a CT. I would say that's the next direction. We really need to understand some of those higher risk phenotypes. But you can definitely separate between calcified and non-calcified plaques. It's now, I was just going to say, yes, earlier last week, there was included the radiology benefit managers. United Healthcare just announced that they're covering AI quantitative coronary plaque analysis. That was last week or so where they announced that. So we'll see that increasingly. There's, Medicare coverage in place, and also the private payers are going to starting to pay for this. So how do we put this together? So one of the things I've been really interested in for the last decade is how, can we, again, think about this, Bromwell model and say, how do we identify high-risk lesions that may benefit from PCI? Because I think where we're going to go, there will be FFR negative lesions that are really high risk, that maybe have a large translesional gradient, but technically FFR negative. And there'll be some FFR positive lesions that will be relatively low risk. So how do we integrate this information about plaque together with physiology in a non-invasive manner? So about a decade ago, I started working with Bang Kwang-Koo in Korea, starting to think about how do we put all this information together to understand information about plaque characteristics from CT, lesion geometry, physiology together, to understand how do we, when we have an imbalance between strength and stress. So the first paper study we did was called Emerald 1. What was shown in that is if you take percent stenosis as a reference, if you have either adverse plaque, high-risk plaque features, or a large translesional gradient of physiology, FFR, you had an increased hazard ratio up to 3.7 for identifying lesions that were causal of ACS. If you have them both together, it goes up to almost 12. And how this study was done was really clever. The study was done in a way where it was patients that presented at cath with ACS, where the culprit lesion could be adjudicated in the cath lab. And then the investigators went and said, okay, did that patient happen to have a CT done in their past? The CT was analyzed blinded to which lesions were culprit, which were non-culprit, and the question is, could you discriminate culprit from non-culprit lesions? So that was the lesson from this study was, first of all, the best predictor was a translesional gradient, physiology gradient, the delta FFR CT across that. It was associated with a high risk of rupture, beat out all the other plaque characteristics, percent diameter stenosis, et cetera. There's a subsequent study that was done, completely different technology. It was Canon's technology, different investigator, showed the same thing, best predictor of plaque rupture. This is called the Destiny trial. And then just last year, Bang Kwang-Koo led an effort called for Emerald 2, much larger cohort of patients, 351 patients, all that have ACS, that had a CT done in their past, and it was the same questions, like could we, if we read it, do anatomic read, is that better? Can we add to that by doing AI quantification? That was the question. And there were a whole bunch of features that showed up. The delta FFR CT was the best predictor of plaque rupture, again, in this new cohort of patients. And the primary endpoint was looking at the incremental value of the AI features on top of the qualitative read. And there's a derivation cohort and validation cohort, met its primary endpoint. The trial was positive. But the other interesting thing that was done in a secondary endpoint was as follows. The question was, if you have, the AI method alone, is there any value, if you just use that, is there any value of human interpretation on top of that? And it turned out that the answer was no. For the derivation, also for the validation cohort. That's maybe in some ways is a good thing, because I'll tell you the human interpretation was done in one of the world's best CT core labs. That is obviously not what you're going to get for every study. So the question is, can we get to the point where we have an automated algorithm method that will identify high-risk lesions using AI, based interpretation? And I think this is possible. The other interesting thing that was done in this study was to look at, and this is, I think, this idea of explainable AI, interpretable AI. So this is what's called a Shapley analysis. You can take any individual lesion. There's a lesion A, lesion B. Turned out lesion A ruptured, lesion B didn't over that time course between the CT and when lesion A ruptured. And the question is, what are the characteristics that were best predictive of a plaque rupture? And the delta FFR CT for lesion A was really high. It was 0.14. Lesion B, it was low. It was only 0.02. So you can basically rank these characteristics and say what contributes most to plaque rupture. But the more important thing, I think, is that you can look at this idea of a time to event. So now think through this. You have lesion A. Now imagine you have all this, prospectively, patients not had an event. You're looking at their CT scan. You say there's a lesion A. Well, that lesion A is high risk, but it accumulates risk rapidly, right? I think, whereas lesion B, it gets to a higher risk, but it happens over a much longer period of time. I think that there are lesions that you will see on a CT scan that you would predict would have a very high probability, very high risk, and will accumulate risk fast. Those might be the lesions that are best intervened upon, right? Because you don't have time for medical management for some of these cases, right? But on the other hand, if you have something that takes longer, it's lower risk, it doesn't have a high risk phenotype, then maybe those lesions are the ones that are safer, to treat medically, even, aggressively or not. I think as we go forward, we're going to have a new lens to say, how do we identify, this kind of holy grail, right? These plaques that are more vulnerable. How do we do it non-invasively and then provide that information to manage patients more or less aggressively based upon the available data? Okay. So last thing, this has been much discussed here. I won't talk a lot about it. The demos I saw, I have to say, is very gratifying to me because I think this is the power of this type of technology. You can't do this with diagnostic imaging. You image the patient at a single time point. You can't predict what would happen in the future if a certain intervention is done. And obviously, PCI has evolved over time, right? We're getting away from just looking at the lowest value of FFR to understand, well, does it get low because there's a gradual drop in pressure along the length of the vessel? Those are not good candidates for PCI. Typically, when PCI is done in those cases, you typically less often see relief of symptoms in those individuals or reduction of risk. So the whole idea was, if we want to understand how lesions are important, let's just take them out, remove them, and predict the post-PCI physiology, actually model the changes in blood flow that would occur with removal of the lesion, and to be able to look at individual lesions, to look at lengths of disease and say, how would the physiology change? This was first validated in what's called a P3 study. By the way, there's no P1 or P2. There's a P3, which is predictive PCI planning, and then there's the P4 trial that kind of in CT-guided PCI. But this was the first one to look at predicting post-PCI physiology. It turns out, for a number of reasons, it's easier to predict FFR after an intervention than it is before. For a number of reasons, but good results, mean difference 0.01 plus minus 0.05, 97,000 matched locations because it was a motorized pullback. Very elegant study done at Carlos Collette's site. And then Yader and others have talked about this and their work in the P4 clinical trial. And of course, it's wonderful to see, sorry to flash that by so quickly, Yader, but wonderful to see the progress in actually thinking about how to bring this in. So this is a great study. There's the Fast Track Cabbage trial. I think this will also go forward into the future to think about how do we start to use this to plan procedures, to plan a revascularization. Patrick would always talk about like having a heart team decision-making based upon non-invasive data, make decisions before patients in the cath lab, try to get an imager together with an interventional cardiologist with a cardiac surgeon. And this will be the path. I want to say just quickly this is something I'm actively working on, a role of CT in the evaluation of microvascular disease. This happens to be my CT scan. You don't see anything beyond the major vessels there, right? And most of the circulation is missing in a CT, so how could we possibly evaluate microvascular disease? We can do a great job of this in a cath lab. And I'll tell you, before Nico and Bernard published this paper, they reached out to me and they said, we're going to do this paper's coming out. This may be what I think is true, is one of the most elegant ways to do coronary physiology in microvascular assessments. But the question is, could we start to do this, think about how to do this non-invasively? So we started working on this. And the challenge is that non-invasive perfusion imaging techniques, the problem is you get just total coronary flow reserve, right? Flow limitations. You cannot separate disease in the epicardial from the microvascular circulation, or even a patient who's hypotensive. FFRCT is based on an assumption of normal vasodilatory capacity. So it will be false positive. It could be false positive in a case where you have a blunted microvascular response. Doesn't happen that often, but it does happen. So that's not ideally suited for that. But what if you put it together? You could put CT together with perfusion imaging, and this is what we're doing. This is a study be presented in September to actually combine perfusion imaging together with CT to extrapolate from these vessels you can see in the large coronary vessels to the microcirculation, link it together, and compute a microvascular resistance reserve non-invasively. We'll see where this goes. There's I would say a steep climb ahead, but I think it's going to be possible to at least offer some insight for some patients in microvascular dysfunction. So conclusion, I talked about most of these things. The technology's here. I think we'll see a lot of new opportunities going forward into the future. It's in clinical practice guidelines. In September, there'll be another meeting at the Heart House to talk about how quantitative plaque assessment should be, how ACC should be thinking about this going forward. Again, coming back to Brownwell's diagram, there's a role for non-invasive technology, non-invasive testing. It's not an either or versus invasive assessment. It's a first, second perspective. Sorry, I think I had that. So we spent a long time doing this. I'll tell you the final step about the journey. I actually hired the first employee at HeartFlow almost exactly 16 years ago. My former PhD student, I had a conversation with him at Starbucks. I said, I've got this idea. I don't have any money to pay you, and I'll pay you out of my pocket, to get started. There's the first employee. The announcement was last week that HeartFlow is doing its IPO coming up. It's a long journey, and what I'll tell you is that I might not have done it if I had known how difficult it would be. But I think the point is about any journey like this, is that, it's not smooth, right? It's difficult. There are many near-death, existential threats, near-death experiences, for the organization. It's hard to do this, but I think any budding entrepreneurs, anybody interested in translation of technology, I still feel it's important. In order to maybe bring ideas forward and to ultimately, hopefully, have patient impact. And a lot of challenges along the way. So thank you very much. Oh, I was going to say, one more slide. This is a good book Peter Thiel wrote. The idea is called 0 to 1, and it's about how, when nothing exists in a space, it's hard. His thesis is that it's harder to go from 0 to 1 than from 1 to many. It's still hard to go from 1 to many. But the idea is when you introduce something new and different in a space, it's extra difficult. But I'll leave it with this patient, Dennis Dorrance. It's a video on the website. But that's what I'm most proud of, is the number of patients so far that I hope have benefited from these products. So I'll end there and be happy to take questions.
Thank you so much. That was amazing. Yes, so much information, and there's so many ways to take this. Let me take the first question, and I think there is so many ways, like I said, we can discuss this, but I want to focus more on the disruptive innovation, because part of this is innovation, and we have a lot of young folks and early career folks here that hopefully will be defining the future of cardiovascular treatment and diagnosis. So can you give us some ideas? You said there were a lot of near-death, a lot of tough events. It was maybe if you had known the journey, maybe we wouldn't even have done it. So what are some of the tips? Give us 3 or 4 of, if you have a disruptive idea, and it may not even be a technology, it may be a clinical pathway, it may be an idea to make care better, more collegial, more team-based. What are your suggestions in regards to disruptive innovation?
I think the first thing I would just say is, be humble, have humility. When I had this idea, the first thing I wanted to do is, the people who developed invasive FFR, to have a conversation with them, say, this is what I'm doing. Because I think when you want to, I was never wanted to displace invasive fractional flow reserve. That was never the objective. But I felt like this could be used, together, in conjunction with invasive physiology. This is physiology that was done, with CT versus in the cath lab. And I would say just have some humility. I mean, the problems that you all work on, the real life situations in patients are extraordinarily complex. They're so difficult. They're so much harder than most problems that people work on, anywhere in the world. I worked building aircraft engines before I went to, grad school at Stanford, in doing aircraft engine design. That's simple compared to a human body and physiology. So I think that's the first thing. And by the way, I would say for a person who's like technology oriented, be comfortable with being uncomfortable. Because when I started as my grad student, I was in vascular surgery. I had a wonderful collaborator, an advisor, my PhD co-advisor, that ultimately became my colleague and co-founder of HeartFlow. But if you're if you have a technology minded, be humble, but also get uncomfortable, because to learn with a technical background, my background is mathematics and engineering. I've learned a fair bit about physiology and about coronary artery disease, but I'm not a physician. So having some humility but also just working through that discomfort, that you have. From a clinical perspective, what I would say is that, look, the truth is for physicians, all the technologies that you use, your work with companies will make these better. There's no doubt about it, So obviously figure out where the barriers are or the boundaries are in doing that, but lean in. Every single product. Manos and I were talking earlier, today. I was like, go tell these people that are building these products what you want, and then if they don't give you what they want, go to their competitor. Because you have a lot of leverage. You want the best things for your patients and the best products for your patients. You have a lot of leverage, in that regard. With regards to starting a startup, it's just be persistent. There's one of the people wrote this great book about startups. Actually, his name is Ben Horowitz, and he's the Horowitz and Andreessen Horowitz. And one of the biggest venture capital firms. But he said when he was CEO of his company, he said he slept like a baby. He woke up every 2 hours bawling his eyes out. And the truth is that's why after 13 years, and my 14-year-old twins were born after I started HeartFlow, I thought, okay, this is wonderful, it's great, but it's time to do something a little bit less stressful. I would just say be persistent, lean in, and maybe the final tip I would get is that never raise money when you have to raise money. Because I'll just give you an example of near-death experience. HeartFlow, we've missed our primary endpoint for our second diagnostic accuracy trial. It was published in JAMA still, but we missed the primary endpoint because we didn't control adequately how the CT acquisitions were being done. About 30% of patients had no sublingual nitrates, so the vessels weren't vasodilated like they are during invasive FFR. Missed the primary endpoint. If we had not raised money before that happened, HeartFlow wouldn't exist today, because there's zero chance it would have raised money after missing primary endpoint of a pivotal clinical trial. And then then we figured out what went wrong, how to resolve through that. Turned out I was glad that we learned that lesson, but it was really painful. But there's a whole bunch of things like that along the way, but I don't regret doing it, but it was definitely the hardest thing I've ever done, including raising 4 kids.
Okay, questions from the audience. Questions for Dr.
Just raise your hand and I'll bring the microphone to you if there are any questions. If no, there you go.
I want to ask you a quick question. Why do you think that your technologists are better adept at extracting the coronary anatomy in their workshop in Austin or California and not trained physicians?
Yeah, that's a great question. And we looked at that. And I don't think that they're not better at reading coronary CT data. But what they are trained to do is to do one specific thing. There's a software program to look at where automated results produce results to interpret, inspect, and correct those results. They're trained typically over about 8 weeks by many very experienced physicians. The whole training program was built by some of the best readers of cardiac CT. They're not better at reading cardiac CT in general. And I wouldn't even necessarily say they would be better than a level 3 reader doing the same job. But when you put it in that type of circumstance, again, they're not making medical decisions. They're looking at the image, the computer result in the context of the medical image data. Then what they do is very highly controlled, and the setting is done where you can continually check the work that they do along the way. You can monitor whether whether they're maintaining the same standards. So I think it's really like the process that was created with the software that was created to do it that made it, very precise to be able to do that interpretation.
I was actually looking for a slightly different answer.
Yeah.
Do you think that the knowledge of the patient's clinical profile would contaminate the interpretation of the images?
Oh, well, you mean, for instance, if a physician was biased because they knew something about the clinical story, that is very possible that was the case. In fact, all the people that do this analysis, they just see the CT data. They know nothing about the patient beyond that. So it is possible that if one had an understanding of the patients, of the symptoms, that they might be biased to interpret the data a certain way. I had an experience where I brought the technology for reading. So once FFR CT was done, some of the physicians said, well, why don't you just give us the anatomic information, to help. We got to interpret a CT scan. We got to call these lesions, et cetera. Just give us that information. You're clearly doing it. And so that was a product that's called Roadmap that HeartFlow doesn't charge for, but that helps with the anatomic interpretation. And I had the opportunity to bring this to actually, I'll just tell you Cedars-Sinai, and they'll tell you the same thing. When they first looked at it, they said, well, we don't think it's going to be very useful to us. They were very expert readers, cardiac CT readers. And by the way, John Lesser from Minneapolis Heart said, you might find, what was it? It was find things that I miss, but can never miss anything I find. I think that was what he had said, which is absolutely correct, right? The expectation is perfection. But I brought this into Cedars-Sinai, and they said, well, we don't think it'll be useful. After 90 days of using it, they went to their administration. They said, we will no longer read cardiac CT without this technology. And they were, some of the best readers in the world. And it's helpful, but it's never going to replace a physician's judgment. It's like a preview, a way to look at the data, the information, and then maybe draw a physician's attention to some parts of the anatomy that they had not looked at otherwise. So again, I think there's value, but it's only when used in complement, the physician's judgment.
Charlie, what just amazing, inspiring talk. Can you speak to the people's component that you were able to achieve? You're a scientist, PhD, but you were working with radiologists and know probably more physiology and plaque than anybody here in the room. How were you able to achieve this multidisciplinary collaboration, communication to bring it now to life? We're very interested in that.
Well, I think it's just, I always look at it. I started HeartFlow, and it was from the technology in my lab, but I've never been CEO of the company. And the reason for that is I felt like there's better people that understand business than I do. So it's all about being a team, right? It's about how do you, and I would always say to the people at HeartFlow, it's like, we got to get a team out there, but I love baseball, and I've coached baseball. My son plays baseball, but I would always say, it's like, if you're going to be playing third base, you don't run over and try to cover first. You got to play your position and get the right people in different roles. I think that's really important. And the truth of the matter is that starting a company, it's probably like many things in life, the hardest thing that, in my experience, you have to do, it has nothing to do with like the technological challenges, the scientific issues, adoption. It's all about people in your own organization. And it's how do you get people to work towards a common goal, over a long period, even when things get difficult. In that regard. So I think it's about the things that we learn about interaction and about coaching that I think is most important. But as I said, I try to, in HeartFlow, I'm no longer there, but I try to, get people to think about, like, any decision you make, stay on the high road. Make the decision on the high road. No matter what happens, make a decision that's going to be consistent with the best interest of the physician and the patient. And those are, it's just a philosophy that I think translates to a lot of things, perhaps. But, none of us know everything, right? But what we have to do is we got to figure out how to work with people that are experts in a certain area. So, I've learned an incredible amount from Nico, from Bernard, from Saroy's, from, also from you as you've started to use use some of these products. And I think that's what it's all about, right? It's, we do this. What you do is incredibly important. I know that when I've had in a number of situations, my mother-in-law who had a STEMI, like I knew when she was where she was going. We're as a patient or family members, we're trusting you to care for our loved ones. And obviously, I think the people who build the products, build the technology, have a role in that to try to help you do your job more easily and better. I don't know if that answers your question yet. Or, yeah.
So Charlie, again, phenomenal work. We had a session today on wellness, and what motivates people, the burnout.
Yeah.
Now, you've been extremely productive over the last 30 years. People, you would think you were very successful in everything. You're starting a new position. You seem to be highly energetic. So how can people be like you that we want to move on? What excites you and what is in the future?
Yeah, thanks for the question, Manos. Yeah, it does. You know, there have been various times in this journey where, quite frankly, it's absolutely exhausting and, you know, makes you completely crazy. But, you know, it's for me, and I tell my kids this, I don't feel like I've ever worked a day in my life, you know, that it's a privilege to be able to do something that you really enjoy. And you don't feel like you're working, right? Of course, yeah, that's not exactly true because there are definitely days where it's like, oh my God, I got to grind through this day. But you know, what I will tell you, I told all my students this at Stanford. I thought I had created this philosophy, but it was the idea I would say, what do you love to do? What are you really good at? And what does the world need? Figure out the alignment of those three things. Find a career that's based upon that. I realize that there's a Japanese philosophy called Ikagi that's been around probably for, I don't know, 1,000 years. And it's those three things plus what can you get paid to do. I always assume that if you love it and you're good at it and the world needs it, you can figure out the career, the financial part of it. But these are the advice that I always give. I give to my kids. I give to everybody. And probably all of you are doing that, right? You've figured that out, and then things are easier. But for me, I started HeartFlow only for the reason, you know, of being able to bring these ideas out into clinical practice. And for me, I feel like I've got a lot of unfinished business. I'm starting to do some work in other areas of disease. I feel like I've beat on the coronary circulation long enough. It's time to start to look at other clinical problems. You know, it's just never feels like work. I met Michael DeBakey, by the way, in his 90s. He came to Stanford, and I hosted him, and he was still going strong. All right, Eugene Bromwell's still going strong. Yeah.
That you were going to also talk about. For some reason, I had it in my head that you were also going to talk to us about expanding this into the peripheral space, like doing the same sort of computations in peripheral vascular disease. Is that something that you have already started working on, or?
Yeah, it's something I was interested in before, and it's absolutely something I'm starting to think about now. I think there's a lot of opportunities for that. I actually just started a collaboration with a vascular surgeon at Houston Methodist to start to think through this. I think it's a great opportunity. I think there are other vascular beds where it's obvious, but there's other clinical problems where this kind of combination of, you know, imaging, computing, AI is really powerful. What I think for the heart, for the coronary arteries, what is powerful about this type of technology? It's not like a medical record, right? Where it's not just putting data together. It's being able to have a way of predicting what might happen. You know, there's people that work in the field that are starting to think about how do you predict progression or regression of disease? How do you build models for that? How do you try to use this information to understand, you know, benefits of alternate therapeutic strategies? So I think that's where it's powerful, and there's many areas of medicine. I came back into academic role at UT because new hospital we're building, like this is one of the technology pillars of the new hospital, what's being referred to as medical digital twins. We're building a hospital, you know, that will have some of these things native. And I think we're going to see more and more of that. I personally feel I know I would say at least 10 really significant clinical problems with big opportunities where this type of approach could be useful, and maybe many of you have many more ideas than I do, but I think it's going to be more commonplace. Imaging is incredibly powerful, right? But it's telling us what's there about a patient at an instant at a time. How do we leverage that to try to go and project into the future? But yes, the answer is I'm starting to think about that again. Yep.
Wonderful. Any other questions? If not, again, CVI is about learning, connecting, and inspiring. I think we got all three of them, especially the last one. So thanks so much, Charlie, for inspiring all of us.
Yeah. Thank you, Manos. Thank you.